Hello, I'm Jason Howland. Welcome to Speaking of Health, a place to help you learn how to live a longer and healthier life. Acid reflux and its primary symptom of heartburn is a common problem that affects many people, and often many times a week. And sometimes it can be a very serious problem. Our guest today is Dr. LeRoy Hodges. He is a general surgeon at Mayo Clinic Health System. Dr. Hodges, thanks for joining us today.
Thanks for having me. Happy to be here.
Well, heartburn happens to a lot of people. I'm sure most of our viewers have experienced heartburn at some point in their lives. Let's start by explaining what exactly acid reflux and heartburn are.
Heartburn is the symptom that most people have. Acid reflux is the cause. So, for example, when we eat, the stomach makes acid to help digest our food. Well, that acid is supposed to stay in the stomach and pass downstream. The esophagus itself, the swallowing tube, is not built to handle acid at all. Some people, however, for a number of different reasons, can have reflux of acid or acid washing up backwards. That acid in the esophagus causes irritation and can cause a burning sensation. That's the most common form of heartburn symptom.
So heartburn is a symptom of acid reflux. What is heartburn?
Heartburn is the symptom that the majority of people describe, which is a burning sensation behind the breastbone. Well, that's where the heart is, of course, and so it ends up being heartburn because it feels like it's burning near your heart.
But it has nothing to do with the heart, right?
When it's actual heartburn, that's correct.
Right.
That's one of the dangers, is to make sure that people don't mistake a heart attack for heartburn. Remember, heart attack symptoms are highly variable. So when people have pain in the chest, the first thing they need to do is make sure they check out the most life-threatening possible problem. Then we can worry about heartburn.
So heartburn, it's a burning in the chest, behind the breastbone. Does it occur at certain times of the day more often, or?
Some people can get it any time of the day, but the most common times are after meals, and particularly after supper when you go to bed. If people eat late particularly and go to bed with a full stomach, then they have a lot of opportunity for stomach contents, including the acid, to reflux into the esophagus, causing this burning sensation.
So let's talk about medications. There are so many over-the-counter medications, and you see ads for them all the time on television. Do those medications work, first of all? And then when should you really be concerned and see your doctor?
That's a really good question. There's a lot of medications available over the counter now for good reason. The most common and basic medications are called antacids, and they're simple chemical compounds that neutralize acid. The old school way of doing that was taking some baking soda. Not many people do that anymore, but Tums, Maalox, that sort of Rolaids, those all can neutralize acid. It doesn't last very long because it just gets rid of the acid that's right there. However, we've noticed over the years that even the prescription medications that we use to suppress acid were very safe, so a number of them have become over the counter because of their safety profile. So we have medications like Prilosec OTC, which was the original purple pill, that can be very effective. When people need medication once or twice a week, and that works well, it's perfectly fine to take it. When you start getting acid symptoms more frequently, or the medication isn't working, you should see your doctor.
So if acid reflux isn't properly treated, what can happen? I would assume acid in your stomach, it's okay, but acid elsewhere in your body is not a good thing.
That's correct. And as we talked about, the lining of the esophagus is not built to handle acid. So when the acid washes up into the esophagus, it causes irritation. It can do worse than that. It can cause actual ulceration. Ulceration means basically the lining of the esophagus is burned away down to the middle layers. You might imagine it like a cigarette burn of the skin going through the first couple layers of the skin.
And probably pretty painful, I would assume.
It can be quite painful. It's, again, highly variable. That can cause pain. It can cause bleeding. It can also cause scarring on a long-term basis, such that the opening of the esophagus gets narrowed, even to the point where food can get stuck.
What about precancerous changes to the esophagus?
In small percentages of patients, the chronic irritation of the acid causes the lining of the esophagus to try and change to something that can handle acid. And it changes to something that looks like the lining of the stomach, but actually under the microscope is more like the lining of the small intestine just past the stomach. And that does handle acid better. Unfortunately, it's an abnormal change and has a higher tendency to turn to cancer than normal tissue. It's still not the majority, most people who have that precancerous change don't get cancer, but you got to keep a closer eye on them.
All right, so as a physician, someone comes in having problems with acid reflux. What kind of tests are there out there to check that area of the body?
Well, the first simple test is for people who haven't really tried much. So the first thing I'll do is put them on a strong acid blocking medication. And if that works, we're pretty much done. However, most of the people who come to see me have already tried that and they're still having problems. So when their symptoms aren't controlled by medication or they're having complicated problems like trouble swallowing, we'll often do what's called an upper GI endoscopy. We look with a scope into the esophagus. In medical circles, we use a big long word called an esophago-gastroduodenoscopy, and that just describes what we look at, the esophagus, the stomach, and the small intestine. And we can look, we can take pictures, we can even take biopsies with that instrument to try and find cause of the problem as well as look for potential dangerous problems.
Now, I've also heard of an ambulatory acid test. What exactly is that?
That's a useful test in people that we're treating for acid reflux where we're not having much success and we're getting to the point where we're considering surgery to prevent reflux. That's a very effective operation, but it's really only indicated for a very small percentage of patients. But I'll give you an example. If we do an upper GI scope for someone who complains of uncontrolled acid reflux and we don't see obvious evidence of that, we can do this ambulatory acid test. Ambulatory means it continues while you're walking around. And it literally is a scope where they go in, they take a radio probe that you pin to the inside of your esophagus with a dissolvable pin. It stays there for a couple of days, the pin dissolves and it passes. While it's there, it measures the actual acid in the esophagus, because there isn't supposed to be any, and sends the readings to a belt pack. So we can watch for about 48 hours how much acid washes up into your esophagus and when it washes up. And we can frequently pin that to when you're having symptoms. Do you complain of heartburn when there is actually acid in your esophagus? And that can help us determine if you're a candidate for surgery.
So let's talk about treatment. And I know you mentioned some of the medications like the antacids earlier. With all of those medications out there, how do you know which one you're supposed to use?
We typically use a stepwise approach. So people will try antacids first. If they take it infrequently and it helps a lot, great. The next step in an over-the-counter medication, which used to be prescription, are the classic ulcer medications from the 60s and 70s. Tagamet was the original. That's still available. We more commonly see Zantac or ranitidine. That's called an H2 blocker or a histamine 2 blocker, which blocks a strong percentage of the acid that the stomach makes. The next step is called a proton pump inhibitor, which almost completely blocks the acid that the stomach makes. It's more effective, as you can imagine, a bit more expensive. The original purple pill was Prilosec. That's now over-the-counter, and it's called Prilosec OTC, which of course stands for over-the-counter.
So some of those medications that you mentioned, eliminating acid in the stomach or reducing acid in the stomach, you need the acid in the stomach to digest your food, so can that be a bad thing or not?
Interestingly enough, blocking the acid in the stomach rarely causes much trouble with digestion. And if it did, what we would notice would be malabsorption. People would eat and they would still lose weight, and their bowels would cause lots of problems because they wouldn't be absorbing their food. We don't really see that, interestingly enough. So obviously there's enough overlap of the different digestive enzymes that people still are able to digest their food well. On the other hand, we worried about long-term use of the medication in the early years of its use with some animal studies that suggested maybe some dangerous consequences. Human studies have never supported that. So in other words, we don't have evidence that long-term use of Prilosec, for example, or Nexium causes cancer. We worried about that for a bit, but we haven't seen the evidence. We prefer it when people can go off medications as they get better, but if a small percentage need to be on it long-term, then we found it to be safe.
So what about surgery? You mentioned that a little bit earlier. Is that the last course of action?
It's definitely the last course of action. There's been a bit of pendulum. Do you operate early? Do you operate late? Clearly, most patients are well controlled on medications. So the small percentage of people who don't do well on medications are the ones that are candidates for surgery. Surgery works well, but it has its own potential complications, and sometimes it doesn't work so well. So there are a number of procedures. The classic procedure is a laparoscopic procedure through these little tiny incisions where we loosen up the top of the stomach and wrap it around the end of the esophagus, causing essentially a new valve to prevent reflux. The big lesson we learned early on is you have to wrap it really loosely, because if you wrap it tight, you can't swallow at all. We learned that 30 years ago, so it's a well-developed operation in the small percentage of patients who need it.
So what are some of the risk factors for acid reflux, especially chronic heartburn? What can be done to prevent it?
Some of the risk factors aren't under our control. For example, some people might develop a hiatal hernia. The diaphragm separates the chest from the belly, and the esophagus goes through the diaphragm in an opening called the hiatus. If that hiatus stretches open, you get a hiatal hernia and the stomach starts to slide up into the chest, and that contributes to reflux. But other things that we do have control over, lifestyle issues, obesity. Heavy people have more pressure on their belly, causing more pressure in the stomach, forcing fluid up into their esophagus more. Smoking, we know, paralyzes that natural valve and causes more reflux. Pregnancy is just more pressure on the stomach and also can cause more reflux. Diabetes can cause the stomach to not empty well. A full stomach causes more reflux. Certain foods can contribute to reflux. We know caffeine can contribute to reflux, and unfortunately that's in chocolate, so that's really a sacrifice to give that up. Other foods like acid foods, orange juice, tomatoes can promote reflux. So if you can modify some of those lifestyle issues, modifying one doesn't make a big difference, but if you try and look at all of those things, it can make a fair difference and minimize your need for medication or potentially surgery.
How about when you eat food and how often or how much you eat?
Very good point. If you eat smaller meals more often, you don't fill your stomach up as much, reducing pressure. The worst problem we see is when people eat late at night and go to bed with a full stomach. That's the classic time when people get a lot of reflux. So when people eat no later than 6 o'clock, try to limit their liquids late at night, go to bed with a stomach that's more empty, it leads to less reflux and often weight loss. When I snack at night, I gain weight, which causes more reflux.
Dr. Hodges, what about elevating your head when you're sleeping? Will that help as well?
It really does. Remember, gravity is our friend in that circumstance. When you're standing up, it's hard for acid to reflux because it goes downstream. When you're laying down, everything's on a level, and that acid can wash up much more easily. The best way of doing this is to put a couple of bricks under the head of the bed, raising it up 2 to 4 inches. When you do that, you have just a little bit of a slope so the acid tends to go downstream the way it's supposed to. You don't want it so high that you slide to the bottom of the bed. That'll particularly anger your spouse when they don't have reflux. You also want to avoid tight-fitting clothing for the similar reasons that we've talked about, avoiding extra pressure on the abdomen. When you put several of those together, you can make a big difference in the reflux problem.
But if you have heartburn, just elevating your bed's not going to go ahead and cure it overnight.
Correct.
Right.
But if you put that together with modifying your diet, not eating late, maybe taking some over-the-counter medications, you can make a big difference.
All right, so we're just about out of time. Any last words of advice for folks with heartburn?
Yeah, several points I want to make. Remember, if you have some minor reflux that happens occasionally, it's just fine to take over-the-counter medication. When it's not being handled by the medication, when you're having trouble swallowing, when it's happening at night or you're having trouble breathing, those are warning signs that you need to see your doctor. There's also been some things in the local media about developing esophageal cancer, which of course is a dangerous cancer. Small percentages of patients with acid reflux problems can lead to development of cancer. However, typically that's patients who have had acid reflux for many years. Those kind of patients, we want to be seeing their doctor. Even if you control your acid reflux well on medications, if you've had acid reflux for 5 to 10 years, see your doctor, because we'd probably do one upper GI scope to make sure there are no precancerous changes. If they haven't developed, you probably won't develop them in the future, and you're pretty safe. If you do have precancerous changes, you're still likely to do well, but you need to be checked every couple of years to make sure you keep it in check or catch it early.
Well, unfortunately, we are all out of time, but I would like to thank our guest today, Dr. LeRoy Hodges, General Surgeon at Mayo Clinic Health System, for joining us. Thank you very much.
Thanks for having me.
Have a great day, everyone, and be healthy.